Okay, chapter 11 of EKG, introducing the heart block rhythms. Go ahead and buckle up because this is where it starts to get a little bit more fun. So, of course, as always, we're going to remind ourselves about the electrical conduction system. And then we're going to talk about all the different blocks. So we've got first degree, second degree type 1, second degree type 2, third degree, and then we'll talk about the clinical significance of each one of these. So let's shift our focus here, as we said, to heart blocks. So these rhythms are categorized based on where they originate within the heart. Now in a heart block, the SA node still generates impulses, but those impulses get blocked or delayed as they travel through parts of the heart's electrical conduction system. So while the SA node is doing its job and sending out signals, sometimes going wrong with that conduction system that's supposed to carry those signals through the heart. Now, if there's a blockage or delay in the conduction system, it can result in a partial, an incomplete, or even a complete blockage. So these rhythms, which are primarily caused by issues within the heart's conduction system, are what we refer to as heart blocks. So essentially, it's just a disruption in the normal flow of electrical impulses through the heart. Now, heart blocks can vary. They might be permanent or temporary, and some can be minor while others are much more serious. However, what's most important is a patient's clinical condition. So how the patient is presenting is the best indicator of how significant the heart block is. So the electrical impulse begins in the SA node. From there, it moves through the atria using the internodal pathways. That's what gets the atria to contract and push blood into the ventricles. But when we talk about heart blocks, we're looking at situations where this electrical pathway gets interrupted. So a block can happen at different points, slowing or completely stopping the impulse from getting to where it needs to go. So this could lead to slower heart rates or even missed beats depending on the type and the severity of the block. So once that electrical impulse that travels through the atria, we're just going back to kind of the normal. It hits the AV node, which causes a brief pause. That pause is really important to remember because it gives the ventricles enough time to fill with blood before they contract. From there, the impulse travels down to the bundle of His, which then splits into the right and left bundle branches, carrying the signal to both ventricles. So this whole process ensures that the heart beats in a coordinated way, but if there's a block in any of these pathways, it can affect the timing and the efficiency of the heart's pumping. Now, after that impulse travels through or moves through the bundle branches, it reaches the Purkinje fibers, which spread throughout the ventricles. So remember, these fibers are responsible for distributing the electrical signal quickly to the ventricular muscles, and that ensures that the ventricles contract effectively and pump blood to the lungs and to the rest of the body. So if there's any disruption in this pathway, the ventricles might not contract properly, which can lead to issues like heart blocks, where the electrical impulses don't travel as they should. Nothing new here, same thing if you've watched any of these, our EKG videos, you've seen this a lot, as well as that boy. So let's talk about the first degree AV block. So it happens when there's a delay in the electrical signal traveling from the atria to the ventricles through the AV node. Now in this case, the impulse is still getting through, but it takes a bit longer than usual. So on an EKG, you'll notice that the PR interval, which is the time it takes for the electrical impulse to move from the atria to the ventricles, it's prolonged, so more than 0.20 seconds. Now the good news is with first degree block, the impulse does eventually make it to the ventricles. So there's no missed heartbeat and the heart's rhythm stays relatively normal. It's often not a huge concern by itself, but it could be a sign of some underlying issues like heart disease, so we do want to keep an eye on it. So now this first degree block, it's not technically classified as a dysrhythmia because it doesn't cause any missed heartbeats or irregular rhythms. It just means there's a delay in the electrical signals as they pass through the AV node. So the impulse gets through, but it takes a little longer than it should. While it's not usually a big problem on its own, it does serve as a warning sign that there might be an issue with the heart's electrical conduction system. For example, it could point to things like increased vagal tone, which slows down the heart, or heart disease. But many people with first degree block experience no symptoms at all, It's also important to remember it's just a delay. It's not a complete block of the signal, so the heart continues to function normally overall. Now, first-degree block can pop up in people who don't have any history of heart disease. And you might even see it in young healthy athletes. So it's actually not all that uncommon in people who are in good physical condition, because athletes tend to have a slower heart rate, which can sometimes cause a delay in electrical conduction through that AV node. Also, medications can also play a role in causing this delay. So beta blockers, calcium channel blockers, digoxin, those are all meds that can slow down the heart rate, and they might also contribute to prolonging the PR interval. So if someone's on these meds, that might be part of the reason why they have that extra delay in conduction. Now, in most cases, though, first-degree block doesn't need treatment unless there's an underlying issue causing it. It's usually just a sign that the heart's electrical system is a little slower. So when a patient is diagnosed with an MI, it's crucial to be on lookout for the possibility of more serious heart blocks developing, particularly because the AV node is often affected in heart attacks. So if the heart block progresses, it could lead to more serious conduction issues. Now, in first-degree block, the hallmark on the EKG is that prolonged PR interval, which is anything greater than 0.20 seconds. It's the only real change you'll see in the strip for this type of block, so it's pretty easy to spot. Just keep in mind that while this is usually benign, if someone is having an MI, you want to keep an eye on how things progress. Sometimes what starts out as a mild delay in conduction, it can evolve into a more serious block, like second-degree or even third-degree block, which may require a little bit more interventions. So let's take a look at our table here. So the rate, based on the rate of the underlying rhythm, the rhythm's usually regular, P waves all the same. The difference that we see is that length of that PR interval. That's greater than 0.20 seconds. And then our QRS less than 0.12. So really the only thing here is the length of our PR interval that we're going to be looking at. So when we look at this, we see it looks quite regular. Looks like it's about 70 beats a minute. Rhythm looks quite regular. P waves are present and upright. That PR interval, though, looks to be probably somewhere around 0.24 seconds. QRS is nice and tight. So remember, we need to identify the underlying rhythm. So this is a sinus rhythm, but it's also a first-degree block. Now let's move on. So second-degree type 1 block. So that's also known as a Winky block. It's generally considered less serious than type 2, which we'll be talking about, but here's how it works. There's a progressive delay in the electrical impulse as it moves through the AV node. So this results in the PR interval gradually getting longer with each beat. Now eventually the delay gets so long the impulse is not conducted to the ventricles at all, and the QRS complex is dropped. So this means that you'll see a missing beat on the strip, which is pretty characteristic of this type of block. So while it can look a bit alarming at first, second-degree type 1 usually isn't a huge cause for concern, especially if the heart rate is relatively stable and the patient isn't showing signs of distress. However, you still keep an eye on it because the block can progress to more severe types, particularly in the presence of heart disease or an MI. If the rhythm remains relatively stable, patients might not need aggressive treatment, but monitoring is the key to make sure it doesn't progress to something more dangerous. So the thing with this is, in second-degree type 1, the pattern is repetitive, meaning that the progressive delay in the PR interval, it happens consistently with each cycle. So as the PR interval lengthens, eventually you'll see the impulse doesn't reach the ventricles at all. So no ventricular contraction occurs for that beat. Now when this happens, the QRS complex is dropped and the ventricles don't contract during that moment. Because that impulse is blocked before it can get to the ventricles, the ventricular rhythm becomes irregular, while the atrial rhythm typically remains regular. So the atria keeps firing away normally, but the ventricles don't always respond, leading to that irregularity in the ventricular rhythm. So it's like a missed beat or a drop beat that creates that irregularity. So even though the atrial rhythm stays regular, you'll notice the irregularity in the ventricular rhythm when you're monitoring or looking at the EKG strip. Keeping track of this can help you decide whether the condition requires further intervention. So it has a characteristic pattern of progressively lengthening PR intervals, as I said, until one QRS complex is dropped, meaning it doesn't get conducted to the ventricles. So the cause of this block often involves abnormal conduction of impulses at the AV node, and this can happen for several reasons. For example, that ischemia, that lack of blood flow in the AV node, can interfere with normal electrical conduction. And then medications like digitalis can also precipitate this type of block by slowing the conduction of the AV node. Now, additionally, an increase in vagal tone, which can be triggered by things like deep breathing, vomiting, or even certain meds, can slow down the conduction of the impulse, and that can lead to winky block. So it's important to know that this type of block may not always be serious. Sometimes winky block can be transient, meaning it can just go away on its own, just kind of comes and goes, but it should still be carefully monitored. So especially if any of the causes like ischemia or drug toxicity are present. Now looking here, all the same things. We see atrials unaffected. However, we see the ventricular rate usually slower than the atrial. The ventricular rhythm is irregular. We do see P waves. The length of the PR interval progressively prolongs until the QRS is not conducted. And then it's typical the QRS is going to be normal. So this sounds a little bit odd. So we're talking about the ventricular rhythm is irregular. However, it is in a pattern. So let's take a look at what that looks like. So when we come down here, let's just start right here. That's pretty normal looking. We see it's getting progressive, lengthening even longer, and we see a missed beat here. We know that because we see that big old blank spot right there. So when we're looking for a rhythm, we notice that it's not regular. We notice there's a drop beat because we have a P wave. However, we don't have a QRS. Same kind of thing. So start here. We see it. And remember, you'll hear it says like going, going, drop, going, going, gone, or longer, longer, drop. That's not always the case. It's not necessarily just 2 beats and then a drop beat. It can be 3 or 4. That's just something that gets said. But in this particular scenario, we have going, going, gone. So you see how it just marches itself out. So really it's irregularly regular or regular, regular, irregular because it has that pattern. So it is an irregular beat. However, it's regular because it continues on and on. It functions in that pattern. So this would be a second degree AV block, Mobitz type 1 or winky block. And then another example, we'll come down here left to right. So we see it getting really long, super long, drop beat. And that's a winky block. All right, now second degree type 2, also known as a Mobitz type 2. That's a more serious dysrhythmia compared to the first degree block or the Mobitz type 1 that we were just covering. The reason it's more concerning is that it often indicates a higher risk of progression to third degree block or complete heart block, which is a life-threatening condition. So what happens in Mobitz type 2 is there's an intermittent interruption of conduction. So this typically occurs near or below that AV junction. So essentially some of the electrical impulses fail to get through the AV node, but it's not as predictable as in type 1. So unlike type 1, where you see a gradual increase in the PR interval length before a drop, in Mobitz type 2, the PR interval remains constant before the drop beat. So this makes it less predictable and much more dangerous. Now when you see this rhythm, it should raise some red flags for possible progression to that complete heart block. So immediate evaluation and monitoring of the patient is crucial. Some patients with this type of block may need a pacemaker to prevent complete blockage and to maintain an adequate heart rate. So the SA node in this rhythm is still generating impulses at a regular rate. So the P waves are occurring regularly across the EKG strip. But here's the key thing. Some P waves are not followed by a QRS complex. So this is because some of the electrical impulses are getting blocked at or below the AV junction, which prevents them from reaching the ventricles and causing a contraction. So this type of heart block is more serious than type 1 because it has a higher chance of progressing to a third degree or a complete heart block. So it causes an irregular ventricle rhythm, but the atrial rhythm will stay regular. Now that's due to that fact that while the atria are still being paced by the SA node, the ventricles are not always receiving the impulses needed to contract. So unlike second degree type 1, where that PR interval progressively lengthens before the QRS is dropped, second degree type 2 usually shows a fixed PR interval that doesn't change before the QRS is dropped. So this is more dangerous form of block because it can happen suddenly without warning and can lead to more severe rhythm disturbances. So when you see this on your EKG, it's crucial to pay attention to their clinical condition. This type of block often requires a pacemaker, as we mentioned, to prevent it from progressing further. Now, in this situation, the impulse is blocked in one of the bundle branches, and there's a partial block in the other bundle branch. Because of this, the QRS complex will be dropped, meaning the ventricles don't contract because they didn't receive the electrical impulse they needed to activate. Now, remember the AV node, that is that gatekeeper to the ventricles. It controls whether the electrical impulses can pass from the atria to the ventricles. So when the gatekeeper, that AV node, decides that the impulse shouldn't be conducted to the ventricles, it closes the gate. When this happens, the impulse can't be conducted through the bundle of His and to the ventricles. Now, in heart block situations, especially with second degree type 2 or third degree, this is what's happening. The gate is closing at certain intervals, blocking the impulses from getting through, causing the ventricles to miss a beat or a few beats, and possibly leading to an irregular rhythm or even a complete block where the atria and the ventricles are completely out of sync. So some of the P waves will be unaccompanied, as I said, by a QRS, meaning no ventricular contraction happens after those particular atrial impulse. This is where things get a little tricky in the terms of rhythm interpretation. So in this type of block, you'll often see a ratio of P waves to QRS complexes, and it can vary. So a typical example could be a 2-to-1 ratio, meaning for every 2 P waves, 1 QRS is conducted, or 1 QS complex is conducted. It could also be 3-to-1 or even 4-to-1 in some cases. The key point here is that while the P waves might remain regular, the QRS complexes are dropped, creating an irregular ventricular rhythm. Another thing to note is that when those QRS complexes, when those are conducted, it's typically widened greater than 0.12, and that's because the impulse that reaches the ventricles is traveling through abnormal pathways due to the block, which causes a delay and results in a wider QRS. Now, this type of block is more serious because over time it could progress into a third degree block where no impulses are getting through to the ventricles at all, which is a real concern. So the PR intervals for the beats that are conducted, meaning those with a QRS complex following the P wave, they are regular. So you'll notice that the atria are still firing at a consistent rate. That means that the atrial rhythm remains regular because the P waves are being generated normally. However, because the impulse doesn't always make it through to the ventricles, the ventricular rhythm becomes irregular. And this happens because some of the beats are dropped. Remember, that's no QRS complex follows certain P waves, or they're non-conducted. So that result is an irregular ventricular rhythm where sometimes there's no beat after P wave, which throws off the regularity. So just to sum it up, the atrial rhythm is regular, but the ventricular rhythm is irregular due to those drop beats. Now, this type of heart block can be associated with some pretty serious conditions like an MI, where damage to the heart muscle impacts the electrical conduction system. So other causes include septal wall necrosis, so damage to the heart septum, and then of course an MI or acute myocarditis, inflammation of the heart muscle, and advanced artery disease, so where the coronary arteries are narrowed or blocked. So whether a patient shows symptoms really depends on the ventricular rate. If the ventricles are still contracting at an adequate rate, the patient might not feel much, but if the ventricular rate drops too low, patients might experience symptoms like dizziness, lightheadedness, or even syncope, so they might faint. So it's a good example of how the clinical picture of the patient is key. Sometimes the block may be asymptomatic, but if the ventricular rate is slow, it can cause some real problems. So when we look at this, we see the atrial rate's regular, the ventricular rate may be bradycardic, but we know that it's irregular. when we look at the rhythm. So is there a P wave before? Yes, but some are not followed by a QRS. And the length of the PR interval is constant for conducted beats. So let's take a look at what that looks like. So we can see here we have a normal beat here. We can tell that we have some missing stuff. We got some more missing stuff. However, we know by the rules, and we're going to talk about this in a second, we're going to kind of just do a down and dirty version of these by using the PR interval. We see this PR interval as constant. So we have missed beats, but the PR interval is constant. Remember, our type 1 was just lengthened. Type 2 was progressive. Now we have a constant PR interval. And that's what we'll see with Mobitz type 2. Once again, we have a normal sinus. Now when we look at this rate, we see only 4 beats out of this. So 40 beats are being conducted, are perfusing beats, right? Because we have missed beats here and here. So we would probably expect that this patient might be a little bit symptomatic, potentially. But everything else looks pretty normal. QRS looks normal. P waves. So this is a second degree type 2. And then again, same thing. These are P waves here. And this is a 2 to 1. So we have 2 P waves to 1 QRS. Now let's get on to third degree. So third degree, also called a complete heart block, definitely the most serious type of heart block you'll encounter. So what happens here is that the electrical impulses from the atria are completely blocked at the AV node, and the ventricles don't receive any impulses from the atria at all. So the atria and the ventricles are essentially out of sync. The atria continue to beat at their own rate, but the ventricles are left to pace themselves. So the ventricular rate is usually very slow and inefficient, which can lead to poor cardiac output, and if untreated, asystole or complete cardiac standstill. So in this case, the heart's struggling to maintain any sort of rhythm, and if the ventricles can't generate enough forceful contraction, blood won't circulate properly, which we know can be life-threatening. So that's why third degree heart block is often referred to as a lethal dysrhythmia. It's critical to act fast or it could lead to death. So with complete heart block, it's a matter of the ventricles not receiving the signals they need to contract, and often the ventricles take over, but they do so at a slow rate, which can result in symptoms of shock, dizziness, fatigue, in severe cases, as we mentioned, cardiac arrest. Now the atria and the ventricles are essentially completely separated electrically. So the electrical impulses from the SA node that usually travel through the AV node to reach the ventricles, they can't get through at all. So as a result, the atria and the ventricles are forced to beat independently of each other. So the SA node, which is still working, will continue firing its impulse at a normal rate. You know, we said usually 60 to 100 beats a minute. However, since the AV node isn't conducting those impulses to the ventricles will start firing at their own rate, much slower, usually around 20 to 40, and the ventricular rhythm is typically very slow and inefficient. Now this disconnection between the atria and the ventricles, it creates 2 separate rhythms, one for the atria, driven by the SA node, and another for the ventricles, which might be coming from an escape pacemaker within the ventricles itself. So the result, well, the atria and the ventricles don't work together, and the heart's pumping efficiency can plummet. So the ventricles end up being paced by an escape pacemaker. Now that pacemaker can come from either the AV junction, which is between the atria and the ventricles, or from the ventricles themselves. Now if the pacemaker is in the AV junction, the QRS complexes will be narrow because the impulse is still being conducted somewhat normally through the His-Purkinje system. But however, if the pacemaker is in the ventricles, the QRS complex will be wide and bizarre looking, since the impulse has to travel more slowly through the muscle tissue rather than the usual conduction pathway. So that rate for these escape pacemakers is usually pretty slow, around 20 to 40, which is far too slow to maintain effective circulation in the body. This is why third degree heart block is considered a lethal rhythm if left untreated. You know, it's basically the body's last ditch effort to keep the heartbeat going. But as you can imagine, it's often inadequate to sustain life. So AV disassociation. So that term is used because the atria and the ventricles are no longer in sync. They're basically working independently from each other. So they're not talking at all. So here's what happens. The PR intervals will be variable because the atrial rate and the ventricular rate are no longer connected. They have their own separate rhythms. So some of the P waves might get buried inside the QRS, making them difficult to see on the EKG strip. But you'll see a regular pattern of P waves and a regular pattern of QRS complexes. But there won't be any meaningful connection between the two, and this is the hallmark of AV disassociation. The heart's essentially out of sync between the atria and the ventricles. So this situation can be pretty dangerous because neither the atria nor the ventricles are working together to pump blood effectively, which can lead to a significant reduction in cardiac output. So what did we talk about here? We said atrial rate is going to be 60 to 100. Ventricular rate, that's going to be based on the site of the escape pacemaker. And we see that the atrial rhythm is regular, the ventricular rhythm is regular. However, there's no relationship to the QRSs with each P wave, as well as one of the big things is that when we look at that PR interval, we see that it's totally variable, so there's no pattern. And in the QRS, do they look alike? Yes, based on the side of the escape pacemaker. So they could be narrow or they could be really wide and aberrant and wacky looking. So let's go ahead and get down here. So right off the bat, we've got a missed beat, so we know we're dealing with a block here. Now, what we were talking about, we see these P waves. There's going to be a P wave in here, and then you see it keep going quite regular. When we look at these ventricles, we see that they're quite regular. However, these guys aren't connected. They're not talking to each other. So one of the big points that we made was that PR interval. So when you look at this PR interval, remember we talked about that it was lengthened. We talked about type 1 or Winkie-Bach was progressive. Type 2 was constant. This is variable. So you see this much space. We got back to normal. We've got all this. So this is variable PRI. When we get down here, we see the same kind of thing. So P wave, really long PR interval, much longer PR interval. There's no consistency here between these PR intervals at all, between the P wave and the QRS. And one more. So we got P waves, lengthened. This is almost like if you looked at it backwards, it's similar to like a Winkie-Bach because it's going. However, it's not because Winkie-Bach doesn't go backwards. So we see our long PR interval, it's starting to narrow. We have P waves throughout. So third degree heart block. Now, this isn't in your book, just something I put together, but this is kind of a cheat sheet, almost a cheat code for blocks. So when we talked about, this is the word that you see that's in the parentheses and all caps is the PRI, the PR interval. So remember, first degree just has a lengthened PR interval. That's how to quickly discern the difference between a first degree heart block and something else. When we look at type 1, remember that it's progressive. So we see going, gone. It's progressive. And then type 2 is constant. So when we look at these, we see that for the ones that are there, we see that it is a constant PR interval, meaning it's the same, right? And then when we go to third, we see variable, and we're just all over the place. So we have a bunch of different PRIs. That will help you a lot with your differentiation of heart blocks if you'll use it. However, you don't have to. So, first degree heart block, let's talk about the clinical significance. So like we've talked about, by itself isn't typically a huge concern. Essentially a delay in that electrical conduction between the atria and the ventricles. It doesn't usually cause immediate issues. However, if this block occurs during or after an MI, it's important to keep a close eye on the patient. Here's why. It could be an early sign that the heart is progressing toward a more severe form of AV block, like second degree or third degree. So in these cases, the heart's ability to conduct the impulses may worsen, leading to more dangerous situations where the atria and the ventricles aren't able to communicate effectively. So while first degree block isn't usually life-threatening on its own, if it pops up in the context of an MI, it could serve as a warning sign that more serious blockages could develop. Now let's talk about Winky block, or second degree AV block, Mobitz type 1. Typically a temporary condition, and occurs when the electrical signals between the atria and the ventricles are progressively delayed until one of the signals is dropped entirely, meaning just that impulse doesn't make it to the ventricles. Now, good news, as we said, in many cases this type of block resolves on its own and the heart returns to a normal rhythm without any intervention. It's often seen in conditions like MI or vagal tone. As I said, it can be influenced by stress or medications. Since it usually resolves on its own, though, the treatment generally just focused on monitoring the patient closely. In fact, it's often not considered dangerous unless it's associated with more severe conditions like ischemia, or if the heart's ability to pump blood is compromised. So really here the key takeaway, while it can cause some skip beats, it's often transient and doesn't require any aggressive treatment in many cases. Now Mobitz type, sorry about that. So it can be tricky because even though it's transient, it has the potential to compromise cardiac output if the pattern involves a rapid rate or if the drop beats are happening frequently. So when this occurs, the heart might not be able to pump enough blood effectively, leading to symptoms like dizziness, fatigue, even syncope. It's important to stay vigilant though, especially since Winky block can sometimes progress to a more serious form of heart block. So if the patient has increasing frequency of drop beats, or if more advanced heart block develops, the situation could become much more serious and may require interventions to maintain an adequate heart rate and rhythm. However, Winky block is usually transient, as we mentioned, so just some monitoring is going to be essential. Now, however, if the patient is symptomatic or if the rhythm becomes unstable, that's something you're going to have to kind of shift gears and probably do some things. Now, that's where I was headed to, was Mobitz type 2. So much more serious condition than Winky block because it has a higher risk of progressing to third degree heart block. So unlike Winky block, where the PR interval gradually lengthens until a beat is dropped, Mobitz type 2 typically has a consistent PR interval, but suddenly one or more QRS complexes are dropped without warning. So the key issue here is that the frequency of those drop beats can cause serious hemodynamic instability because the ventricles are being skipped, not receiving that impulse to contract. So it could result in an inadequate heart rate as well as compromised cardiac output. Now, the more frequent the drop beats, the worse it can be for the patient. So it's also worth noting that Mobitz type 2 can deteriorate quickly into a complete heart block or third degree heart block, which obviously, as we've mentioned, can be life-threatening. Now, with Mobitz type 2, the cardiac output can be seriously compromised because the heart rhythm becomes more irregular, leading to missed beats, insufficient blood flow to the vital organs. So when you're dealing with this, you need to be cognizant for signs and symptoms of decreased perfusion, like hypotension, shortness of breath, dizziness, chest pain, confusion. Because this form of heart block can progress to third degree heart block, it's essential to stay proactive. So you want to watch for these symptoms closely, as they can indicate that the patient isn't getting enough oxygenated blood to their body. Now, if left untreated, it could be life-threatening, so you may need to intervene quickly, potentially by pacing or other methods, which would be pharmacological. And then our third degree, or our complete heart block. Here we're dealing with a lethal dysrhythmia, meaning it's potentially life-threatening if not managed properly. So in this situation, the atria and the ventricles are essentially out of sync, as we said, each firing independently. So the SA node in the atria might be firing at a normal rate, but the impulse can't get through to the ventricles due to that complete block at the AV node. So those ventricles will eventually pick up the slack and start pacing the heart, but at a much slower rate, usually around 20 to 40, which is far too slow to maintain adequate circulation. So you might see in these patients, typically with signs and symptoms, they point to some severe hypoperfusion, just meaning that the body isn't getting enough oxygenated blood. You could see some severe hypotension, confusion, or even loss of consciousness, fatigue or weakness, shortness of breath, chest pain as well. So this condition can progress rapidly, and immediate intervention is crucial to prevent fatal outcomes. So treatment usually involves temporarily pacing to regulate the heart rate and ensure adequate perfusion. Now, sometimes patients may require permanent pacemaker implantation if the block is permanent or recurrent. Now, if the QRS complexes are narrow and the patient appears asymptomatic, it often means the AV junction is acting as the backup pacemaker, which is sending out those signals to the ventricles. So the AV junction tends to pace the heart at a slower rate, but as long as the patient is stable and asymptomatic, it can sometimes maintain an adequate cardiac output. However, if the patient starts to show symptoms like dizziness, hypotension, shortness of breath, then the heart is not pumping effectively enough, and in these cases, treatment will likely be necessary. So atropine is a common first-line med to temporarily increase the heart rate by blocking the vagus nerve, which normally slows the heart down. However, atropine may not always work in complete heart block, especially if the block is located below the AV junction. So typically, when you look at that QRS, if it's nice and narrow, atropine is a really good option. However, if you look at that QRS and it's really wide and aberrant in a third-degree block, it's probably going to be a waste of time. However, you need to make sure you follow your local protocols. Now, pacing. So if those symptoms persist or if the atropine doesn't help, then we probably need to do some pacing. That'll help to ensure the ventricles are paced at a more appropriate rate. So that pacemaker can override the block and regulate the rhythm, and that prevents further complications and ensures adequate perfusion to the vital organs. So if that patient shows signs and symptoms and they have a wide QRS, we're probably going to need to move on, as I said, to TCP, transcutaneous pacing. That will be necessary, followed by obviously a pacemaker, at the receiving hospital or wherever. But if it's wide and aberrant, remember that's probably not a very good candidate for atropine. So when we look at all of this, remember we always want to make sure that we're talking to our patients. We always want to make sure that if without talking to them, I guess that's not completely true, but for the most part, it's hard to figure out how symptomatic someone is. Now, if they just have a garbage blood pressure and their color is bad, you don't really need a whole lot of words to tell you that. However, make sure that we're not just using an EKG strip analysis alone, that we're communicating with our patient as well. All right, let's take a look at a couple here. So we see we've got P waves, P waves, P waves, P waves all over the place. So it's variable when we look at our PR interval. So what do you guys think? I think that looks like a third degree to me. When we look at this, we see P wave connected to our QRS. P wave connected to our QRS. We have a rate of 30, 60, 70. Looks pretty regular on both sides, atrial and ventricularly. So our PR interval, though, whenever we look at this, 3, 4, 5, 6, 7 maybe. So we know that it's a lengthened PR interval. So using our little down and dirty cheat sheet thing earlier, a lengthened PR interval, first degree block. And I'll let you look at that, but let's move on to another one real quick. Okay, let's look at this one. So here we've got probably just lengthened just a bit. We do notice that we have everything's going along here. We have a P wave to each QRS, and then we have a P wave with no QRS, and we have a gap here. So we know we've dropped a beat. If we go on back to our discussion that we had, we see we have somewhat normal, maybe a little bit lengthened. However, it's getting more and more lengthened till we drop a beat. So it's progressively getting longer, that PR interval. So that looks like a winky Bach. What do you guys think? Second degree type 1 winky Bach. And I'll let you do the rest. And that's blocks for you. And last but not least, we have pacemakers coming up. So we'll talk to you then.